Great, thank you. So now I think we can open it up to the floor for just general questions on the webinar topic. So Juliet, if you're online, we can just discuss some topics or questions for both presenters. Yeah, maybe Juliet, if we take another question about community health clubs, there's a question about which to start first, if you're should it be CLTS or start community health clubs, or
okay,
can you combine both?
Yeah, I think well, it's a very different. You know, the community health club is like a basket really, and the CLTS is a one topic intervention. So it makes a lot of sense to me to have a correct entry with the community. Because our health club, it takes quite a lot of setting up. It involves talking to village leaders, it involves enlisting members, and then we give out the membership cards. And as we go through the topics, when we get to the sanitation topic, that's where I think CLTS should come in, because already the community have been prepared. They're already making changes to their water, to their general hygiene around the house, and hand washing. And sanitation is probably the most difficult thing you're going to ask them to do. So my feeling is, human nature being what it is, it's easier to start with small incremental steps, getting people to just, do small things and then build up to the sanitation, which is the difficult one, because it involves digging a pit, or it involves resources, or thatching grass, or whatever. It's a lot of work. And so you kind of build up towards that rather than coming in and expecting people to respond very quickly to something which is quite difficult. So if possible, the way I would like to see it is that community health clubs are started. They may even be started in areas where there has been CLTS already, but it's revisited so that when you come to the village walk, you go through and you assess the situation on the ground, by which stage they'll be telling you what the problems are and what they're going to do about it, rather than coming there with a heavy hand and pointing out all the sort of nasties in the corners of their village. So that would be my perspective, but of course other people may differ.
We had another question, I think, here about whether the latrines would be considered improved sanitation. So Henrietta says there's an issue where building basic latrines, it doesn't, there's no focus on moving individuals and communities up the sanitation ladder.
We very much approach it from the sanitation ladder perspective. Once people understand the concept of why feces are dangerous and how they've got to block fly access to feces, this is the critical thing to understand. Once they understand that, they will find ways to block that. A lot of the latrines are covered, but you'll find a latrine cover over it, and then there's a crack in the floor between the planks, and of course the flies are getting in there, and that means that they haven't understood the concept of why we're asking them to cover it. So upgrading latrines is very important. I'm sure in Bangladesh it would be the same. For example, in Rwanda, the coverage of latrines is extremely high. It's 98, 99%. It's just that those latrines are unsanitary. They have feces and urine and fly access. So we're trying to get people to improve their latrines, and very much it does come up to international standards, which can be counted as an improved latrine. But rather than say, build a VIP or nothing, as used to be in the case in Zimbabwe, we're saying start with what you can do, and anyone, any fool can dig a hole, shit in it, and cover it. That is not rocket science. Everyone should be able to do that. So if you can do nothing else, you've got no excuse. There should be no open defecation. And then start to dig your pit, to line it, to put on the slab, to put a nice floor on, to paint it, put the sign up. That comes later, but at least do something. The basics is ODF or ZOD, and then the latrine standards come according to what the country's standards are, or what the expense, what can be afforded by the household.
Moniril, perhaps you could comment on whether there's any attention to moving up the sanitation ladder as part of your overall intervention or program, or whether that requires attention.
Okay, it's a very important topic, as Juliet already mentioned. Sanitation in Bangladesh is overall is because of we have sanitation, but that is not up to the mark sometimes. So we need to upgrade this to not only the whole or normal latrine. It needs to be a JMP standard latrine. So, but we have already stopped open defecation. So the sanitation it needs time to make 100% to make a very good standard. But in some areas, we have some pockets areas. Those areas are really vulnerable. We have flood problem. We have sometimes disaster in the southern part. So some very difficult to reach areas are vulnerable to this kind of sanitation. So we are working on it. We'll try to address this, but still hygiene is also very important with these sanitation matters.
And we have another question here about whether these approaches would be applicable to urban areas, low-income urban areas. So perhaps both of you could just say a quick comment on that.
Should I go first?
Yeah, sure.
We have had a lot of interesting results with community health clubs in urban areas and peri-urban areas in Zimbabwe. We actually started it as a response to the cholera outbreak in 2008. When there was a horrific scare throughout the country with 4,000 people dying from cholera. And we used the community health club approach in an emergency context there, and it was so successful that we then began to use community health clubs in urban areas. So now most of the towns in Zimbabwe, we've been working with various partners implementing community health clubs in peri-urban areas, and this really focuses a lot on solid waste disposal and just general environment, because the water is usually provided, tap water, but it's just the general environment is unsanitary. And we've had huge successes in cleanups, mass sort of work together, cleaning up an area. The community health clubs have much better interface as a group with the council or the municipality, so the distrust between the two groups, which has grown up in Zimbabwe due to lack of service by the council, it helps to bridge those gaps so that there's a sort of reporting mechanism for any issues which people in the clients or the community have are much better in touch, and then training the council as well to learn how to deal with community and informal settlements and to have open communication. I'd say the community health club approach has got a lot of potential for urban areas.
Okay, for Bangladesh, community health club is extremely important because for the low-income communities in the urban areas, because in this part of the urban section do not have adequate sanitation and also other health related practice, because they are low-income people. They live in the slum. Water is not up to the mark. So extremely important. The approach that Juliet already mentioned is very important in this part. But it would be very innovative, because the club should be maintained, because in the urban area the community is sometimes not willing to join, or maybe they are more into income activities than health issues. So it has to be very more innovative to maintain this community health club in the urban areas.
So thank you very much. I think that we're now running out of time, so I'd like to thank everyone for participating and close the webinar now. But if you'd like to continue this conversation, you're welcome to start a discussion on the Susanna Forum. And you can also find more information there about both of the projects the presenters talked about today. So thank you very much for participating. For anyone that wants to stay and chat for a few minutes on the chat with the presenters, you're welcome to do so.